I'm Mark Pegram, the director of the Breast Oncology Program at the Stanford University in Palo Alto, California, and today I'm going to discuss therapeutic potential of CDK4 and CDK6 inhibitors in combination with endocrine therapy agents in patients with metastatic breast cancer. These are my disclosures. I've been consultant for the manufacturers of CDK inhibitors. So George Beatson published a paper in The Lancet in 1896 documenting therapeutic clinical responses in patients with advanced breast cancer following surgical oophorectomy. So this was really the first connection that breast cancer can be an endocrine-sensitive disease. A century later, investigators in the UK first synthesized tamoxifen in 1962. Originally designed as a contraceptive agent. It was later learned that tamoxifen itself is actually a prodrug that's converted to 4-hydroxytamoxifen and indoxifen, which are the active agents that bind directly to the estrogen receptor in the estradiol ligand binding pocket of the protein receptor. And you can see, based on the crystal structure of the tamoxifen-bound estrogen receptor, that it alters the conformation of the estrogen receptor, specifically the location of helix 12. And what this does is that it interferes with the association between estrogen receptor dimers and estrogen receptor coactivators. The estrogen receptor transcription complex is a large complex not only of the estrogen receptors themselves, but also coactivators and co-repressors indeed. And tamoxifen alters the balance between activators and repressors, and as a consequence, has an impact on ER-positive tumors. Tamoxifen was first approved in 1977 by the FDA, and now it is the world's most widely prescribed anti-cancer agent with more than 2 million prescriptions per year globally. At the bottom of the slide, you can see these results in the early stage breast cancer setting and the adjuvant setting from the Early Breast Cancer Trialist Collaborative Group, showing remarkable efficacy of tamoxifen in the adjuvant setting just after 5 years, with a 39% risk in the 39% diminution in the risk of recurrence and a 30% proportional reduction in mortality. So a very active agent demonstrating the importance of endocrine therapy in ER-positive breast cancer. More recently, we have the advent of other anti-estrogen drugs, namely the aromatase inhibitors on the far left, which block the biosynthesis of estradiol in postmenopausal patients. And as a result, that also disrupts the ER transcriptional complex because it is absent the estradiol ligand. I've already talked to you about tamoxifen, which is an example of a selective estrogen receptor modulating agent that blocks this interaction with estrogen receptor coactivators, altering the estrogen response element-driven gene transcription that otherwise would be driven by estradiol with intact estrogen receptors. And finally, there are selective estrogen receptor degrading agents, such as fulvestrant, that result in polyubiquitination of the estrogen receptor protein, resulting in proteasomal degradation, and that also blocks transcriptional activation of the estrogen receptor. All three of these are approved and are in common use as endocrine therapeutic approaches in ER-positive human breast cancer. With all of this success, why should we need alternative approaches to augment this remarkable efficacy of anti-estrogens? The answer is shown here, once again, by the Early Breast Cancer Trialist Collaborative Group. This is a meta-analysis of 46,000 women enrolled in 91 trials who were disease-free after initial 5 years of endocrine therapy. But what was observed is that there is a stubborn annual event rate of approximately 1.5% all the way out to 20 years. So these are late recurrences in ER-positive early-stage breast cancer. Indeed, all these patients in this meta-analysis had T1N0 disease, as you can see on the right-hand side of the slide. So this is remarkable that despite the success of early intervention with adjuvant tamoxifen for 5 years, there's still late recurrences all the way out to 20 years. Consequently, metastatic ER-positive breast cancer remains a high unmet need, even in the modern era. Now, the estrogen receptor has a number of complexities. Indeed, there are post-translational modifications of the estrogen receptor that can alter the otherwise canonical pathway of ER activation binding to estrogen response elements, turning on the expression of ER-dependent genes. There can be phosphorylation of the estrogen receptor by signaling pathways that can turn on ER activity, even in the absence of estradiol. And there are cell surface anchored, truncated estrogen receptors that may have a negative regulatory effect on ER-directed transcription. This shows some of the sites of post-translational modifications within ER alpha. And as you can see, there are a number of different modifications that occur that are functional, and this can alter the function of the ER protein and change the repertoire of genes that are expressed as a consequence. It's important to note that one of the target genes for ER activation is cyclin D1. Now, the cyclins were discovered more than 30 years ago, resulting in the Nobel Prize in 2001, awarded to Lee Hartwell, who discovered the CDC genes in yeast, Sir Paul Nurse, who discovered CDC2 in yeast in 1976, and later human homolog CDK in 1987, and Sir Richard Timothy Hunt, working in a completely different organism in the sea urchin, discovered cyclin itself. Together, they were largely responsible for the modern understanding of the cyclin CDK complexes and their execution and direction of progression through the cell cycle. Indeed, as shown on the right-hand side, you can see that in the resting state, RB is hypophosphorylated and forms a complex with E2F, and it stays coupled to E2F in the absence of phosphorylation. Coupling enables RB to act as a tumor suppressor in this fashion, resulting in cell cycle arrest. However, when RB is phosphorylated, it dissociates from E2F transcription factors, and uncoupling of the RB protein makes it unable to act as a tumor suppressor, and as a consequence, E2F will turn on the expression of other cyclins and CDC genes, resulting in progression through the G1S checkpoint and beyond. Note that CDK cyclin D complexes, specifically CDK4 and CDK6 and cyclin D complexes, can be activated by NF-kappa B signaling, PI3 kinase AKT pathway signaling, STATs, steroid receptors, as I mentioned previously, MAP kinases, and Wnt beta-catenin signaling can all activate cyclin CDK complexes, resulting in RB phosphorylation and progression and entry through the cell cycle. In the Dennis Slayman lab at UCLA some years ago, Richard Finn and others were studying the activity of CDK4/6 inhibitors in ER-positive human breast cancers with the hypothesis that the most rapidly dividing cells, such as basal cells and HER2-positive cells, may be the most sensitive to CDK inhibition. However, what they observed was the contrary, that luminal ER-positive cells were the most sensitive in cell proliferation assays, whereas these basal cells in yellow and the non-luminal cells in red had no response to the CDK inhibitor palbociclib in the laboratory. Moreover, they found that the sensitive cell lines had higher expression of RB protein and cyclin D1, whereas the endogenous CDK inhibitor P16 protein level, transcript level was actually lower in the sensitive lines as well. So this suggested a clinical hypothesis that CDK4 and CDK6 inhibition may have activity in human breast cancer, and that set the stage for early phase human clinical trials with palbociclib. The CDK inhibitors have an interesting mechanism of action. You can see the crystal structure of one of the CDK inhibitors, in this case abemaciclib, bound to CDK6. And as a consequence of this interaction, there is a unique mechanism of action that involves cellular senescence, as shown here by the induction of beta-galactosidase expression in cells following treatment with an anti-estrogen plus palbociclib. So this is a very interesting and novel mechanism of action that sets the stage for clinical efficacy testing of combinations of anti-estrogen plus CDK inhibitors. Following the phase 1 and 2 trials of palbociclib, there were pivotal phase 3 registrational trials for not only palbociclib but also ribociclib and abemaciclib, all in the CDK4 and CDK6 inhibitor class. You can see that there are remarkable consistencies behind all three of these pivotal trials, all in combination with aromatase inhibitors in first-line ER-positive, HER2-negative metastatic breast cancers. The response rates of all three CDK inhibitors is remarkably similar, around 55% or so, and the hazard ratios for all three of these pivotal trials were highly similar at about 0.55, give or take. Interestingly, the placebo arms with aromatase inhibition alone also had similar median PFS estimates at about 14.5 months. So similar efficacy across the board for this entire class of inhibitors, which is a gratifying result indeed, resulting in FDA approval for all three of these agents based on all three of these pivotal trials. Just to underscore how similar these trials are, here is a superposition of the Mona Lisa ribociclib-letrozole trial along with the Paloma-2 palbociclib-letrozole trial, and you can see that the Kaplan-Meier estimates of progression-free probability are highly similar. The authors note that on a statistical basis, since cross-trial comparisons can sometimes be hazardous, that cross-trial study inferences should not be made. Nevertheless, it's inescapable that these agents appear to be highly similar in terms of the primary endpoint of these phase 3 trials. Moreover, there's great data consistency in terms of subgroup analysis for these agents. I'm showing you the forest plots for the Paloma-2 pivotal registration trial and Mona Lisa-2 registrational trial. And you can see that there's remarkable consistency of the data across many pathologic and demographic subsets of clinical interest. Indeed, the confidence limits of all these subsets comfortably overlap the hazard ratio confidence limits in all randomized assigned patients. There are some subsets of great clinical interest to see what the impact of addition of CDK4/6 inhibition is in patients who otherwise might be considered to have a favorable prognosis. For example, patients older than 65, but surprisingly, even these elderly patients had a point estimate on the hazard ratio to the left of unity, indicating that even these patients derive additional benefit in terms of PFS by the addition of CDK4/6 inhibitors. Also, patients with non-visceral disease also fare very well by the addition of CDK inhibition in addition to an aromatase inhibitor. Those patients with long disease-free intervals, let's say plus or minus 12 months, either way, they benefit. Indeed, disease-free interval of greater than 5 years or even greater than 10 years resulted in hazard ratios of 0.6 or 0.44 with statistical confidence. So even long disease-free interval patients where we might think of using aromatase inhibition alone will benefit more, based on this data, by the addition of CDK inhibitors. Bone-only disease is another well-recognized clinical favorable prognostic group, but they also significantly benefit from the addition of CDK inhibition. And then patients with only one disease site of metastasis also benefit from CDK inhibition. So irrespective of low-risk subsets and multiple clinical, pathologic, and demographic subsets, the data is quite consistent with a clear signal for efficacy in multiple subsets and very consistent with the intent-to-treat populations. A biomarker analysis campaign was undertaken in Paloma-2 as well as in other data sets, trying to elucidate which subsets may benefit the most from CDK inhibition. Despite this enormous effort, there was really no single marker that stood out as predictive of CDK inhibition benefit for the PFS endpoint. Moreover, in the phase 2 campaigns for palbociclib, in biomarker selected patients versus unselected patients, the PFS estimates were almost the same. Consequently, there was no clinical evidence to move forward using a biomarker for selection because the real biomarker appears to be luminal ER-positive patients, pure and simple. There are a number of efforts underway now trying to identify resistance factors, such as cyclin E expression, for example. FGFR amplification has been associated with resistance to CDK inhibition. So has CDK2 expression, overexpression. But there are many more trials that are underway currently trying to elucidate these mechanisms in more detail. The one clear message so far from the available data is there does not appear to be just one mechanism of CDK4/6 inhibitor resistance, but rather a collection of different resistance pathways. And so we'll probably have to pay attention to more than just one for future clinical intervention. Now, in the second line, these agents have also shown impressive clinical activity in combination with fulvestrant. All three CDK inhibitors showed positive results in PALOMA-3, MONARCH-2, and MONALEESA-3. Note, however, that there are significant differences in these study designs. For example, in MONALEESA-2, both first and second line patients were allowed. There were different patient populations between PALOMA-3 and MONARCH-2. Specifically, any number of prior endocrine treatments and one prior chemo was allowed in PALOMA-3, whereas only one prior endocrine treatment and no prior chemo was allowed in MONARCH-2. So one must be very careful to refrain from making cross-trial comparisons amongst this collection of studies. So it would not be fair to compare these hazard ratios head-to-head because quite different patient populations were studied, and consequently the median PFSs, even for the control arms, differ significantly, as do the response rates as expected, given the different clinical features of the patient population under study. So it's very important to not make cross-trial comparisons when the patient populations are so different. Abemaciclib has the advantage of having central nervous system penetration, so for the uncommon occurrence of ER-positive brain metastasis from breast cancer, this probably would get the nod in terms of a preferred agent. There are differences between the degree of CDK4 inhibition and CDK6 inhibition amongst the various CDK4 and CDK6 inhibitors. Palbociclib has low double-digit nanomolar IC50s. Abemaciclib appears to be the most potent with low single-digit nanomolar CDK4 and 6 inhibition, whereas ribociclib has potent CDK4 inhibition but less impact on CDK6. Thus, the ratio is higher there. This has been argued to perhaps be a theoretical advantage by some. However, this is mitigated by the fact that the dose is much higher in the case of ribociclib, and we'll talk about that more in just a little bit. The difference between CDK4 and CDK6 inhibition may, in fact, have some impact on the degree of neutropenia. Particularly CDK6 inhibition may have more neutropenia, whereas CDK4 is more the target for the anti-tumor effect in breast cancer. However, with diarrhea, CDK6 inhibition seems to clearly have an impact in the case of abemaciclib. There's also some low-grade diarrhea with ribociclib. Both of these are more than that observed with palbociclib, and this may be an off-target effect, or it could theoretically also be an effect of metabolites of either of these two agents as well. Ribociclib has some potential for QTc prolongation, so that's a unique feature of this drug. So when you treat with ribociclib, it is necessary to get baseline and post-treatment electrocardiograms to measure the QTc interval directly for continued treatment. There are a number of drugs that can prolong the QT interval. These are available in online computerized databases. You do not need to read all of these. I'm just showing you that these databases are available so that when you're selecting co-medications in patients who may be on ribociclib, please refer to these databases, and most electronic pharmaceutical distributors will flag drug-drug interactions for you as long as patients get their prescriptions filled at the same pharmacy. Some of these are commonly used as supportive measures in oncology, for example, ondansetron, antibiotics, etc. So it is important to review this list in patients on ribociclib to be sure that there's no potential for QTc prolongation via drug-drug interaction. In terms of more safety data, the FDA has recently released this warning about palbociclib, ribociclib, and abemaciclib. Though this is a CME talk, I prepared this slide directly from the FDA website, and I apologize for the fact that they used the brand names. I'm showing you the label language that is now in all three CDK4 and 6 inhibitors. And for this example, I've just called this one CDK inhibitor and trial 1, trial 2, and trial 3, not to single anyone out, but the language is the same for all three. Severe, life-threatening, or fatal interstitial lung disease and/or pneumonitis can occur in patients treated with CDK4/6 inhibitors, including when taken in combination with endocrine therapy. Across multiple trials, about a percentage of CDK inhibitor-treated patients had interstitial lung disease or pneumonitis of any grade. 0.1% had grade 3 or 4. In the pivotal registrational trials, fortunately, there were no fatal cases reported. However, in the post-market experience, there have been some fatalities reported rarely. It's important to monitor patients closely for pulmonary symptoms indicative of this process, especially hypoxia, cough, or dyspnea. In patients who have new or worsening respiratory symptoms or suspected to have pneumonitis, interrupt CDK inhibition immediately and evaluate the patient, perhaps even a referral to a pulmonologist as clinically indicated. If anybody is diagnosed with severe interstitial lung disease or pneumonitis, CDK inhibition is then contraindicated. Now, there was concern in the statistics community as to the ability of any of these CDK4/6 inhibitor trials to have adequate statistical power to critically address the overall survival endpoint. Indeed, in this publication from these investigators, they speculated that based on the sample sizes and power calculations that Paloma 2 and the Mona Lisa trials have limited power for the OS endpoint. Overall, the power of these trials to demonstrate a statistically significant improvement in OS is less than 70%, assuming the prolongation in median OS is less than or equal to about a year, whatever the OS data maturity. This analysis suggests that as these studies are jeopardized by limited power, a meta-analysis might be required to demonstrate OS benefit. So this was the state of affairs prior to the past year when some of the data sets started to report overall survival differences. Now, this plot shows the number of subjects needed based on power calculations for median survivals post-progression out to 24 months. And in human breast cancer, the number is even more than 20 months on average, even after progression on a CDK inhibitor, which the median is about 24 months in its own right, because the median overall survival of ER-positive metastatic breast cancer is in the range of 5 years. Consequently, to have an 80% power, you would need, thousands of patients potentially to critically evaluate the overall survival endpoint. Moreover, there were 7 randomized controlled trials of CDK inhibitors. 3 were with ribociclib, 2 were with palbociclib, and 2 with abemaciclib. So assume just for a moment that all 7 CDK inhibitor trials had equal power. What's the probability that 2 ribociclib trials would be positive? Well, there are 21 possible different 2-trial combinations, 3 of which are ribociclib randomized controlled trials. Therefore, the probability that any 2 ribociclib trials would be positive would be 3 out of 21 or 1 out of 7. However, with only 2 palbociclib trials and 2 abemaciclib trials out of 7, the probability in that case is only 1 out of 21. So if any of them were to be positive, it was more likely that it would be positive in one of the ribociclib trials, just based on play of chance, back of napkin considerations. So what was the statistical power of Paloma 3 for the overall survival endpoint? It had just a 46% power based on 310 mortality events among 520 patients who were enrolled in the trial. Accordingly, an 80% power calculation would involve more than 700 events. So Paloma 3 and other trials indeed were relatively underpowered to critically address the OS endpoint. Despite those statistical concerns, we now have data showing statistically significant and impressive results in the abemaciclib fulvestrant randomized controlled trial, placebo-controlled, OS benefit hazard ratio 0.76 with a significant p-value. The median time to chemotherapy was also significantly prolonged from 22 to 50 months. That's a very important clinical endpoint as well, and an absolute delta in OS of about 9 months. The Mona Lisa 3 trial, similarly, hazard ratio 0.7 with statistical confidence. This crossed the pre-specified boundary for superior efficacy of p less than 0.011. So remarkable data, despite the fact that there was concern that we might not be in the position to see clinical efficacy to the degree of impact on overall survival. Now we are seeing it despite those concerns, which is a testament to the robust clinical efficacy from the CDK4/6 inhibitor class of drugs. Mona Lisa 7, which was ribociclib with endocrine therapy, placebo-controlled. Also, the OS endpoint hazard ratio is 0.7. P-value is significant. So the exploratory analysis of this data set generally showed consistent benefits across various subgroups as well. So this is, again, a 29% relative reduction in the risk of mortality. Now, here are the pharmacokinetic properties of the 3 CDK inhibitors, and I'll just recall for you from a previous slide their known IC50s for CDK4 and CDK6. And since ribociclib is dosed higher, they achieve higher area under the curve, higher Cmaxes than the other 2 agents. And this has been offered as possibly some advantage for ribociclib. However, if you look at these Cmax concentrations and the average concentration, even for the unbound fraction, all of these are comfortably above the IC50. So whether this imparts truly an advantage of one drug in the CDK4/6 class versus another is still uncertain. To be sure, in the case of palbociclib, the unbound average concentration is only about double the CDK4 IC50, but it's still comfortably above that range, and whether this has clinical impact or not is unknown. This is the overall survival in the Paloma-3 population, which was just published recently in the New England Journal of Medicine. And you can see that though this did not quite hit its statistical confidence level, there was a hazard ratio of 0.81 in favor of the palbociclib randomized subjects with fulvestrant compared to placebo. Now, it's important to point out that some of these trials did allow crossover, and that will contaminate the OS signal. In this trial, 16% crossed over from the control arm to the palbociclib arm, which also impacts the ability for this study to demonstrate a statistically significant OS signal. Finally, I'll mention that there is single-agent activity of abemaciclib in heavily pretreated ER-positive metastatic breast cancers with a response rate of about 20% and stable disease of another 20% for a clinical benefit rate of about 42%. So in the salvage setting, even after heavy pretreatment, this may be a meaningful clinical treatment option for a CDK4/6 inhibitor in selected patients. In conclusion, CDK inhibition in ER-positive, HER2-negative metastatic breast cancer remains a substantial unmet need. CDK4/6 inhibitors improve the durability of both first and second-line endocrine responses in patients with metastatic hormone receptor-positive breast cancer, including newly reported overall survival benefits. Future directions will include novel combinations with CDK4/6 inhibitors, for example, in combinations with HER2 targeting agents, clinical investigation in early-stage breast cancer, and attempts to overcome resistance mechanisms to CDK4/6 inhibition. Thank you for your attention.